Hello, everybody. I have got Dr. John Naslund here with me today. John is an instructor of global health and social medicine. He holds expertise in psychiatric epidemiology, implementation science, and digital mental health. John's scholarship seeks to advance efforts aimed at improving the lives of individuals facing the challenges of mental illness worldwide. His work focuses on low-resource settings with emphasis in India and the United States, covering three major areas: the training and building capacity of non-specialist providers, health promotion and addressing excess mortality in persons living with severe mental disorders, and digital platforms for peer-to-peer support and empowering individuals living with mental illness. I first heard John at the Common Table, where he was presenting alongside another person, talking about how they brought a mental health solution into the community via the church, training up essentially everyday individuals to be part of the task force of resourcing and enabling people who are living with significant disadvantage and struggle. So I was really keen to speak with him and to share his work here with you. So welcome, John.
Great. Well, thank you very much, Valerie. I really, I'm really excited to be here and really appreciate the invitation to be part of this podcast and the opportunity to talk more about some of the work that I'm doing.
How did you get into this area, John? What led you here?
So, I guess the mental health work broadly, it stems back from my dissertation work and a really keen interest around severe mental illness, which you mentioned in my bio, and then more recently, this work focused, I think maybe pertinent to your audience, is how did this intersection with faith communities come about in my work? And that's actually been more around keen interests of mine around how do we support the implementation and scale up of proven evidence-based programs and interventions that can help address things like depression or anxiety in community settings. And one of the things that came about through that work was there was a very keen interest among faith communities. They actually convened a meeting, and I was invited to attend this meeting, and they expressed that there was severe sort of challenges within their congregations. This was cross-denomination, and it was really quite humbling and incredible to hear their stories. And that's really where it was sort of like, well, we actually have some proven tools that may be beneficial, and there was sort of a synergy that came about through that, and a key opportunity to address a significant unmet need. It's by collaborating with faith communities.
When you attended this meeting, what were you discerning their motivations were? Were they themselves seeing the burden of mental illness in their churches or their community?
Yeah, so this was a meeting that was convened in 2022, and at that time I was working as part of on a project where our focus was around training community health workers. This was in Texas. This was a part of a statewide initiative to support access to mental health care. And it started with a focus on community health workers, sort of extending the health system. But as the project evolved, it became increasingly clear that the individuals who were most interested in learning the content, like learning how to address depression, were actually representatives of various community organizations, with faith communities being one of them. And this meeting was convened with, as I mentioned, it was cross-denominations. So we had representation from a wide range of different churches and serving varying, demographic groups. And it was the leadership that actually had come together, and they had identified this as a crisis in their congregation. So there were high rates of death due to suicide. So that's been a real serious challenge. And then sort of this feeling of helplessness and not knowing how to respond to these concerns. And that was really, it was sort of a moment where it became clear that actually we have some of these tools, and we're trying to find the right places to make them available to people we could help. And there was a need identified among these faith communities.
Which leads me to ask you, empower? I've actually picked up a paper here this morning, which I hadn't seen, but the title is Toward the Global Dissemination of Psychosocial Interventions. I love everything that Harvard does, because everything it does seems to be global. Studies seem to be things that can be replicated in different cultural and national contexts. Tell us a bit about what this Empower and Psychosocial Interventions is.
Yeah, so the Empower program is really sort of our flagship program through through the lab that I co-lead in our department. And I was one of the co-founders of this program. It started in about 2018, 2019. But really the goal here is we're not trying to reinvent sort of the actual evidence on how to treat something like depression or anxiety. Instead, our goal is to say, there are proven interventions. We call them psychosocial interventions. Sometimes they're called psychotherapy. There's other words for it. But basically, there's a global evidence base. And actually, there's a number of leading trials and projects that have come from Australia. I know that. But really, there's a global evidence base demonstrating the effectiveness of the clinical effectiveness, the cost effectiveness of these brief interventions across a wide range of different settings, and even settings that are unconventional. So there's work from rural India, from sub-Saharan Africa. So really from every corner of the globe, demonstrating that these programs are effective and can be delivered by almost anyone with the right training and the right support. The key challenge, which is really the key focus of my work, is that even though there's this incredible evidence base, there's very little delivery, very little uptake, very little use, especially in lower resource settings. So I do a lot of work with collaborators in India, but also in higher income countries like the United States, where we have huge gaps in access to mental health services. And so we need to think about how can we get programs like this into practice? And that's really the focus of Empower. We're taking these programs, trying to simplify them to make them accessible to virtually anyone, and then using digital technology to support digital tools basically to support training, to support quality assurance, the assessment of competencies, and then the actual implementation and delivery.
Yeah, so one of the guests that we had on the podcast, Dr. Byron Johnson, he kept using a phrase that really caught my attention. And he said that in faith communities, he called them houses of worship. He said a lot of good is locked up in there. It doesn't spill out, or we don't know how to spill that good that we have, that we know through our faith, through our relationship with one another and with God himself, into the community. And I think that is a similar issue with mental health clusters as well. We can be quite siloed in our approach to coming out and being a part of helping the community. In fact, about 2 weeks ago, I attended a dinner in my health network. It's a segment in Sydney. That's how we're segmented. And it was about 200 doctors, psychologists, social workers, mental health nurses, health professionals coming together to try to figure out how do we actually work together and simplify things so that we don't make it so specialized, so expensive, and so hard for people to access this care. With the work, if the Congregational Collective, that's the work with faith communities, is that particularly in Texas, John?
It is, yeah. So the Congregational Collective actually came about. So that meeting in 2022 I mentioned was hosted in San Antonio, and one of the conveners for the meeting is Becca Bruni, and she's now the executive director of the Congregational Collective. The Congregational Collective was established, I believe, in 2023 or 2024. So it came about actually after securing funding. Was one of the outcomes from that initial meeting. And what's been really exciting about the Congregational Collective is that it's essentially bringing together congregations from around San Antonio, and the goal is to expand even beyond that one setting, but really around a focus of building up capacity and strengthening and supporting these congregations in a model where they work together. So it's very, very, very collaborative, but around addressing mental health concerns. So this has been, and so part of this has involved basic training around recognizing, identifying mental health concerns, how to work together, as congregations, how to connect people with services that they may need. And one of the key offerings is, our role, so the Harvard Medical School team role, is around how do we bring the Empower program into these congregations. So some of the participating churches have elected to kind of take their training a step further by doing the Empower training, which involves training in how to deliver behavioral activation, which is a brief psychotherapy for depression and anxiety, but training members of their congregations to learn and master those skills with our support around how to implement this. And essentially, rather than simply referring outside the church, making that a place where there's someone who could learn those skills and respond to someone who has depressive symptoms right there in the church, in a setting where there's trust, where it can be done in a place of comfort, and then also with the kind of support. So it's not just, I guess the other piece by having this collaboration is that this is a proven approach that we're now moving into the church. So it's also grounded in science, but then also really leverages
Well,
the strengths and the values of the faith community to make it work well.
so take us through a typical collaboration between yourselves with Empower and a local church. What does that typically look like?
Yeah, no, that's a great question. So many of the churches that are part of the Congregational Collective, they're quite incredibly diverse in terms of size and in terms of their geographic
Yes.
location, in terms of the race and ethnicity of their congregants and the neighborhoods that they serve, the types of, the variation in socioeconomic groups that are served. So really, some of them are in many very low resource parts of the city. Others are in, more high resource areas. Really, in these congregations, my team, we provide access to our training platform. So we have a program, the Empower platform. It's all a virtual training. We do in-person meetings as well, but we first give access to this training, and we really make that open to anybody in the participating churches who might be
Any
interested in doing this training. Yeah, really,
particular qualifications?
there's no restrictions on who can do it, except that they have to either speak English or Spanish, because we have it
Yeah.
in both English and Spanish. It's really the requirement. So really, the goal is to try to actually think creatively about who can learn this content. So they don't have to have a background in healthcare or mental health. We have people from all kinds of different backgrounds. Some of them are, maybe retired. Others are still, working part-time, and then they're doing this. But they're really doing it because they're a member of the congregation. They're part of their church community. So they can do this training, and then we recognize that it's a significant time demand. I don't want to oversimplify it. There's a lot of content to learn, and even though we make the content approachable, anyone can learn it. But then to go to the next step of actually mastering and using that content requires more time investment. So we recognize that not everyone who learns the content is going to say, yes, this is for me and I want to move on. But for those who do, then we work closely also with clinical partners. So we partner with the University of Texas Health Sciences Center in San Antonio. We work with their licensed clinicians, so psychologists and licensed clinical social workers. And we work with them to then support any of these trainees in really using those skills. So really, how do you then find someone in your congregation who has depressive symptoms? How do you then begin delivering the program? So and I'll just speak briefly, it's a
Yes,
brief
please.
intervention. So it's called behavioral activation, and it so there's a cognitive behavioral therapy, or CBT is very well known, and behavioral activation is actually a component of CBT. It's a simplified component that actually shows similar, if not even superior outcomes to CBT, but it's a little bit easier to learn and master. And what also is really valuable about this program, and that's been helpful through our learning, is it actually is very much complementary with different belief systems, with different faiths. And that's partly why it's worked so well in so many different settings around the globe, whether it's in rural India or now in San Antonio in faith communities. It really aligns, it's complementary to most people's belief systems. So what we have then found, actually, working with the churches, is that we're actually trying to learn from them. How do we frame this so that this program, when we bring it to a church, that it really is complementary to your faith? It actually doesn't, if anything, it might actually help you engage more with your faith. It might help you practice
Okay.
activities that are supportive of your faith, because it really focuses around skills. Think of it as sort of like it's a skills training in some ways, around how to engage in activities that are meaningful, to identify your values and to practice that. And that helps then overcome the symptoms of depression. And
Can you just speak a little bit about what sorts of activities are in the behavioral activation component?
yeah. So the behavioral activation typically is delivered in 6 to 8 sessions. So one-on-one. It can be done like this. It can be done virtually over the phone, or it can be done in person. It's really it's usually based on preference. So it could be done in the church directly, or in in an individual's home, or in another location where they feel comfortable, or over the phone, as I mentioned. And it usually involves walking through identifying values, things that are important to you, and then making sort of a plan to engage in different activities. So it's really around, it's sort of, the core concept is really that if you engage in activities that you care about and track it and do it, and so there's homework, there's you have to follow the steps, then it can really help you overcome the depression, symptoms of depression. And so it's done in a structured way. And part of what makes it work so well is that it's so structured that anyone who uses it, whether it's being delivered within a church in San Antonio, or in Boston or wherever, you can make sure it's done the same way in every single place, which is one of the reasons why it works so well.
Right. So a church says, we'd love as part of the Congregational Collective, they send some people to be trained, and then they are in partnership with the clinical oversight or overseers through this program. Say they finish the training. What happens now in terms of the church getting people from the community? How does that look like?
Yeah, no, that's a great question, and that's something we're still working on. So right now, it's in the context of implementation. So we're actually trying to better understand how to do this, because I don't think there's one correct way to do that right now. So we've been training members of congregations of churches. We use the word navigator. They're called a navigator. And basically for some of them, they are, people are either being sent to them within their congregation because they are not doing well. Then they do a brief screener. So they do, there's a short questionnaire to kind of ask about how are you feeling. And, it starts with either it's a 2-item questionnaire. It's called the patient health questionnaire. It's a PHQ is the acronym. It has 2 questions. If you endorse any kind of concerns on one of the 2 questions or both, then you do a longer version. It's a 9-item. So it's only 9 questions, but that's the first step, is identifying, people who have symptoms. And then symptoms of depression is not, so I also want to make very clear, we're not diagnosing. This is not we're not doing, we're not trying to find mental illness and, disorders. What we're doing is we're finding symptoms, and then we are training members of congregations to then respond to those symptoms. So if they find someone who has, depressive symptoms that would be considered a concern, then they can begin delivering the behavioral activation program to them, and scheduling sessions and then setting that up. So that's been, and we're exploring different ways to find people in the congregations. I know, and it varies by church. One church, for instance, is putting advertisements up. They're putting, like signs and, everywhere, things around mental health awareness. Other churches we've worked with are a little more cautious. They're not sure they want to really advertise mental health like that way. They're a little bit more worried about stigma. So I think the answer is really, we're learning, and I think it might be different in each church or each setting. And I think that flexibility is actually one of the strengths, because in some cases it's a referral from someone who's concerned. In others, it might be just finding someone and asking the questions and identifying it. Other instances, it might be, like I said, you might see an advertisement and then reach out. So I don't think there's not one way to do this, but I think the shared goal is really trying to essentially find people who likely would not have gone to seek help if it weren't for this capacity now within their church.
And so once it's rolled out in the church, my imagination is that most people gather at a church on Sunday. If we're training people from church who have regular jobs, how are they delivering this service? And what does that look like? Are they doing the behavioral activities with the person, as in they're walking with them? Like once it's identified and they go, okay, well, here's a plan for you. Seems like, your values align towards spending time with family. Here are some thoughts about that. Are they doing it with them? How does that work?
Yeah, so they don't, to my knowledge, they don't necessarily do the activities directly with the person they find, but what they do is they schedule follow-up, the follow-up appointments or visits or however, sessions, follow-up sessions. And that's really to monitor progress. So it's not like, there is follow-up, right? So each session, so every time there's a session, they collect a measure of depressive symptoms to see how they're doing. That's also really important because sometimes there's more serious things that can come up, or someone may not get better. That can also happen. And we need to know that, because if that happens, then there is the opportunity for referral. So that's been actually I should have mentioned too, one of the key things is this is not a program that is, in isolation of the health system. That's certainly not my goal. And certainly not, we don't want to try to put all of mental health care onto the shoulders of churches. That's not the goal. The idea is to find people who probably would never have gone in to get help. But if there is a really serious case, we need to make sure that there's a pathway to refer them to care. And that's already been one of the early successes, actually. We've identified some people who've been in pretty significant distress, and they've been referred to a clinic that they didn't even know existed, or they wouldn't have felt comfortable going. But because someone in their church who they trust said, yeah, I think you really need to go to this clinic, they've actually gone, and that's one of the early successes, and we're really pleased with that. And that again, it's one of these things where there's a great deal of stigma in these communities, and then also there's it's not easy to seek help for a mental health issue, but if someone you trust is bringing this
Mm.
forward, there's opportunities to do that. So they don't necessarily, yeah. So back to the navigators, they don't necessarily do the session, all the activities outside of the sessions, but they do
Mm.
schedule regular sessions to monitor progress,
Mm.
symptoms, and hopefully supporting someone as they get better.
And okay, I think I understand. We currently have a program called the Mental Health First Aid Training, which means that we can train people in the congregation to respond to signs and symptoms of a disorder or a mental illness early. But then once that happens, it's then refer on. But this then perhaps provides a next step, almost like a initiating one of the first, I suppose it's transdiagnostic. Behavioral activation is great and helpful across a range of illnesses, mental illnesses. So someone can then go, oh, we flagged or we found or this person has, revealed to us they're actually really struggling. You can then talk to a navigator within the church even. So you can initiate a referral. You can say, okay, let's see about, getting you referred to a doctor or a health professional, but there can sometimes be a wait for that. A lot of times there is a wait for that. So the next step could be a navigator who is able to give that first level assistance and support through Empower. And
Exactly.
yeah,
You're exactly, and I just want to mention that actually the many of the churches we met with, like, so that meeting, that original meeting with the various congregations, many of them had done something like mental health first aid, and there is certainly value in learning that content. But I think one of the challenges is that it's refer on, it's
yeah,
very, very basic understanding, and what
yes,
was echoed across, yeah, almost every congregation that we met with
yeah,
in that meeting, it was that was not enough. They needed more skills, more tools. Basically, what are some of the other things they can do? And then that's when we said, well, hey, we have a program through our lab that this might
yeah,
actually help meet that
yeah,
need. And
yeah,
then that's where the kind of the synergy came about, because yeah, behavioral activation is essentially for many people, if you pay for psychotherapy or you go to a licensed clinician,
yeah,
you'll receive something like this. You would receive. So now we're
yes,
moving that capacity into into a church.
yeah. Who are these navigators? They sound like superheroes. Like life is already complicated and busy and exhausting. And here they are stepping up and saying, no, I want to be trained in this. I'm assuming they're not getting paid for it either. Who are these people?
Yeah, no, it's a great question, and they come from all different backgrounds, all different prior professions. Some have had sort of leadership roles in their church, but they maybe have stepped back. So they were either a pastor, and then now
Oh,
so they have a connection to their church. Others
right.
are not like that at all. They do work in their church, but they came from other professions. We've got, people who are former, were former service members in the military or Air Force, and then now they're doing this. Or we have one navigator who's taken this, really has taken this to heart, and is actually now going back to school to become a licensed clinical social worker. So is almost taking this to now become a clinician, which is pretty remarkable. He did all the training. I mean, I think it's an incredible success story that not only has he done the training, but he's now going to make this sort of a career shift, and because he's compelled to do this within his church. So I think that the one thing that they all share in common is that there's a deep commitment to helping, just supporting their church and addressing the crises that they've been witnessing.
What sorts of shifts and changes have you seen in the churches themselves as they participate? Because I mean, this is, I know as a mental health clinician, my mom used to say to me, you must be so burdened and tired listening to terrible stories all day. And I'm like, actually, no, the most inspiring time I have is with my clients. The government gives me grief with all the compliance stuff I have to deal with. Clients are one of the pure delights of my world. What have you seen it feed back into the faith communities?
Yeah, that's a great question, and that's actually part of the, because so we have a research project embedded in this to really try to understand, first, of making sure this is working, because that's really key.
Mm.
We want to make sure that what is being delivered is achieving We want to make sure that people are getting better. I mean, there's no question there. But also there's another piece too to explore the perceptions of the faith leaders and the broader clergy. I think one of the key things is that has certainly I've observed since starting this project is that there's been a real, I think, increase in awareness around mental health issues. The conversation's happening a lot more. And I think it's interesting. The first, because now it's been since, well, 2024 is when, our team really started working on this project. But in the last 2 years, I think initially there was maybe there's a little hesitancy. Some of the churches were signing on because they knew this was they could see this was a concern, but they weren't really sure about it. Now it's sort of like, oh yeah, no, they're all in. Like they're much more invested because I think they are hearing either they're hearing from their own congregations about the value of, trying to address these concerns, or they're seeing firsthand that this is having, an impact in terms of it's changing the conversation. I think that's a big piece. It's now something that there's less stigma is there. I don't want to, pretend it's not, but there's certainly a shift in people talking about this. I was recently in a meeting where, I was visiting a church gathering in San Antonio, and where they were describing the launch of a new program focused on families. So thinking of mental health and families. I mean, it was incredibly inspiring because this was coming about, engaging about 9 or so different congregations with a focus on supporting families, with mental health being central to that. And I thought this is really, but what I thought was so exciting there is that this wasn't, something that I put forward or our team brought, it wasn't from, academia in any way. This was driven by the churches taking the content that we've provided and adapting it. So I think seeing things like that is really exciting. So the church is taking the mental health training content that we've provided and then adapting it and using it in ways that they see as beneficial. So that's one example. And I think that's really exciting because it means they're taking ownership. They're using it. That's the whole point. That's why, the Empower is not going to it's not going to work if it just lives at Harvard Medical School. It has to be in any communities really, but where it can be used and owned and, adapted in ways that could be beneficial.
Yeah. So I took my AI note taker to the Common Table gathering in Houston, and it generated, all these, summaries for me. And what I've been doing is I've been sharing the link with various groups of people. So I have a team of psychologists in my practice, sharing it with them. But I did take it to one in-person gathering, and these are it's called the Pastors to Pastors Network. These are people who are, support chaplains or mentors, or over here pastoral supervision is a huge thing, who are gathering to talk about, well, how do we actually support pastors better? And so one of the things that I shared was about Empower and the Congregational Collective work. And one person looked at it, and I can see why they said this. And they said, oh, this is a really westernized view of how to address mental health issues. And I said, well, actually, there's work that's, did it originate, Empower is actually in India? Is that correct, John?
Yeah, that's right. Yeah. Yeah. It's a bit more convoluted. The behavioral activation originated in Western countries for sure. But then it was adapted and delivered in rural India. And that was a trial done that work started about 20 years ago. And I think, or even more so now, 20 to 30 years ago, really. And there was pioneering work around taking Western models grounded in the psychological sciences, from, ivory tower settings, mostly, white researchers developed these things and adapted it for the context in rural India. Similar work in parallel has taken place in sub-Saharan Africa. Very similar models have been and have had very, very high success. The Empower program actually took the work from India and adapted it back to the US.
That's it. Yes.
Yeah, kind of where is it? Yeah, is it a program from India or is it? But so we did cultural adaptation for the U.S., but essentially took the exact program that was used in India.
I'm just absolutely thrilled and fascinated by that. One of the things I discovered, I commenced a PhD program, which is very painful for me at the moment, but I started to see that post the pandemic, it's actually developing countries that have an academic community started to say, we can't go through this again, or we can't feel this helpless again. So, in the leadership and organizational studies that came out after COVID, it was things like, how do we make sure that workplace well-being is taken care of? How do we make sure that our leadership is ethical and attuned to the mental health needs of workplaces? So I'd already been seeing that we can't actually assume that some of the struggle and solutions is only coming from the Western world. Actually, developing countries are wrestling with the issues as well. So I'm thrilled to hear that it started from India and we're learning actually how to do that. What generated that research in India? Was it you, John? Is it because you've got links there?
Yeah, so I've now been working in India for close to 10 years, but I started working with an organization there called Sangath, and one of the real pioneers of this work is Professor Vikram Patel, who he's a mentor of mine, and he's the chair of my department. And he, along with colleagues through an organization called Sangath, so it's an NGO, so a non-governmental organization, started in Goa in India, and that was really the organization and Vikram Patel's work that really started this in India, and that's now about 25 or so years ago, yeah, mid-90s, I would say. And then when I started working with Sangath, we were actually expanding to a different part of India. So my work has been entirely in a place called Madhya Pradesh, which is like in the center of India, working in a city called Bhopal. And there's a hub there, a research hub for Sangath. And I've really been working with them primarily. And the focus was less around, does this model of behavioral activation work, but instead, how do we support the scale up? Basically bring it to scale. How do we support scalable training programs for community health workers? How do we do this in rural settings? And working in one of the most under-resourced parts of the country. So that's really been the focus. So I'm not a clinician. My background is really more focused on epidemiology and how do we support implementation. So basically, how do we get things that we know work into practice? That sort of sums it up. And that has been tremendously successful collaboration. Our team in India is actually, they're so much further ahead than our work in the United States in terms of achieving scale. It's inspiring for us because they've expanded to multiple districts in central India that I mentioned, and they've trained thousands and thousands of community health workers, reached thousands of patients, tens of thousands of sessions of behavioral activation have been delivered. I mean, it's really, it's what we're aspiring to try to achieve with our work in Texas and other parts of the United States.
I mean, India and Texas, they're rather different. How do you see how does this work? Why does it work at scale in India and then now in Texas?
Well, there, in some respects, in India, I think some of the reasons why it's worked very well is that there's been a real policy imperative to make it work. So I actually say it's very, very different than the United States in that sense. I mean, they share many similarities for the wrong reasons in terms of, high burden of mental illness and many challenges with, access and so on. But in India, that's been very exciting in the last few years because the government has been rolling out basically national reforms around the health system, and rolling out this, they're basically trying to work towards universal health coverage and in the rural and remote and underserved parts of the country. And within that is rolling out non-communicable disease care programs, so comprehensive primary care services, and it includes mental health care. So that's sort of been what's really helped as sort of the the starting point, because if you have this policy documentation, they also have the Mental Health Care Act in India. It makes it sort of now there's an imperative to make this work. Of course, there's huge implementation challenges, but at least you get this sort of top-down sort of shift towards making this happen. So that's one advantage, I would say, in that work. The United States is a lot different. And our health system is much more complicated. And it is actually, I would say, a little different here. It's driven less by health policy and by health systems and more by community need. And I think the Congregational Collective is a prime example of that, that this is now actually more of a bottom up. This is coming because people are in crisis. And the same is true in India. Absolutely. There is certainly growing, recognition at the community level, but it just helps you have this sort of synergy with the policy and then the community need. Whereas in the United States, it's the demand, I'd say, and the opportunities are now coming about because I'd say in some respects, the situation has become so difficult and so challenging. People are saying we need to take matters into our own hands, learn these skills and do this ourselves. And I'm seeing that not just in faith communities, but I mentioned earlier, we had this, program to scale up depression care across Texas. And some of the very most successful examples had nothing to do with the health system. So we partnered with veteran serving organizations,
Mm.
so they were working, they serve, veterans in different parts of the state. They see this kind of high levels of distress on a, regular basis. They did the training and have since successfully applied this in their programs. Similar with the YWCA, so Young Women's Christian Association, they offer sort of support services, residential facility for women who are typically victims of domestic violence or have experienced homelessness. So not a traditional healthcare provider. They've used this content and then have applied it in their facilities. So I think that to me is very exciting because it means there's a motivation. And I'd say that absolutely is the case with these churches. They see this, what's happening, and they're now taking, an intrinsic motivation to learn the content and to address these needs in their communities. And I think I think it's very exciting actually. And I think
Amazing.
this is where we need to bring mental health care, is outside of clinics,
Yeah.
outside of the formal system, and where people can actually get the help and in a trusted way.
Yeah. So has Empower landed in Australia?
I don't think so yet. No, we certainly have collaborators in Australia, but I don't think Empower has landed in Australia yet.
Can Empower land in Australia?
I think so, yeah. I think there'd be great opportunity. I know Australia is really one of the leaders certainly in youth mental health. There's some of the programs have been really among the top. I know that anytime we're looking at what are some of the best examples, Australia is usually one of the leading places around the globe. But I think it would be very exciting to explore opportunities for Empower in communities in Australia.
Well, if you have a message to leave with us, John, as we wrap up, just from your observation of how faith communities have responded, what would you say to us here in Australia as we start to think about, as we listen to this conversation? What would you like to leave with us?
Yeah, no, I mean, one of the things that I think is really, I mean, to me is actually one of the most exciting things is to, again, just sort of back to that idea of getting mental health care outside of clinic settings.
Mm.
And my work is not, the goal is not to replace clinicians, and it's not it at all. We're not trying to, we're not trying to compete, but we know that the health system and licensed clinicians are, well, one thing, specialist mental health providers are in such short supply.
Yeah.
That's a global, anywhere. And really, we won't be able to train enough to meet need, but I also don't think we need to. I think the specialists can really serve an incredibly important role in seeing the most severe cases, responding to complex needs. So what that means is we have to shift our attention to finding other people who can respond. And I think that's where I'm most excited, is that we can think kind of creatively and outside the box. Like, there's so many different people who can learn these skills. As I mentioned in the congregations, all the people we've trained are all kinds of different backgrounds. And I think even beyond churches, there's so many opportunities to respond to someone in distress before it turns into, a serious crisis. There's ways we can do this earlier in community settings, in comfortable and trusted areas. And I think that's really what I encourage anyone to think about, is really thinking creatively outside the box about who is the right person to respond to a mental health need. And then how do we make sure that we can support them, train them, and then offer the support to make sure they can do it well. And I would say that's just one of the other key pieces in this work, is that training someone to respond to depression, the training's not actually too difficult. What requires a lot of care and attention is, after you've trained someone, how do you make sure they have that ongoing support? A few reasons. One, it's not easy responding to mental health needs. You're seeing someone who's in distress.
Yes.
It can be really stressful on your own. So you need someone you need your own support, actually. And then also, this idea of ongoing support or supervision can be really helpful to make sure that if you run into something challenging, how do you navigate that? So there's this need for ongoing support. So I think that's another key piece, is that yes, we can find people in the community, we can train them, but then we need to make sure that we can support them in doing this well. So I think those are, sort of key takeaways. I think this can work very well in these communities. It's just thinking how to make sure the right you find the
course.
right people and then the right support and infrastructures there to make it work.
Yeah. And to any of our listeners, if this has inspired you, please do reach out, send me an email, and maybe we can start a conversation about how we might be able to see this in Australia. Thank you so much, John, for your time this morning. I've really enjoyed it and appreciated it.
Yeah, well, thank you so much, Valerie. Really appreciate the invitation, and thank you again.